This is my approach. The very first thing is the liposuction, which frees up the skin, allows you to do the closure. So the first thing is the liposuction. I do it bilaterally, and as Joe mentioned, it swells up quickly, so you have to move through this, and then get to your closure. I always use the tail tack method to check my incision. This is done with the patient upright and the arm flexed at the elbow. You want to make sure, one, you've taken off enough or not too much, that there's no rotations of the skin you want to derotate, and you have the results you want. Sit them up, tail attacking, and I remark it if necessary. After a while, you'll find you remarking less and less. It always pays to take a look. Here's the area that's been slightly remarked, as you can see, ready for excision. It's been infiltrated with local anesthesia, Zollican and Marcaine, 1 to 200,000 epinephrine. You take just a superficial layer, almost always involves the entire hair-bearing tissue of the axilla, and there's no substance in terms of perspiration. I leave a thin layer of fat in the resected area so I can remove the eccrine and apocrine glands. You don't leave those behind. If you see some behind, just snip them out at the end. This is the defect. Now, I'm not worried about this because I've checked it several times. I know it can be closed. You can see it's a thin layer of fat only. They're not near the brachial plexus. They're not near the lymphatics. I've done this procedure on women who've had mastopexy, and they've done very well. There's never been a problem. You go back one. You then mark the axillary crease so you know where the hollow is. The closure is very straightforward. I use various sutures. I'll describe the sutures. But as you can recognize, when you close the lips, it becomes longitudinal, it becomes increased in length transversely. Sometimes it's 7 centimeter defect can wind up being 13 or 14 centimeters. To bring the scar